Regarding stool testing, we know that PCR or DNA-based assessments for pathogens, parasites, is validated and has been shown to be more effective and make treatment more successful than more traditional, what's known as antigen recognition, where a microbiologist will examine stool underneath a microscope and look for visual confirmation of a pathogen. And there have been some studies that have found reduced use of antibiotics in those who had symptoms of a parasite but didn't have a parasite. So they've actually enhanced care with the use of the PCR DNA-based testing for stool as compared to the antigen recognition under the microscope, the more kind of traditional types of tests, which have really kind of fallen out of favor. There's also some functional markers. Calprotectin does track with inflammatory bowel disease. However, it's important here to clarify that doing screenings in populations wherein we don't suspect inflammatory bowel disease, this marker may not be helpful. It may elevate in some cases of IBS, it may not in others. So we want to be careful not to use a marker outside of what it's been validated to be diagnostic for. So in this case, we want to be a little bit cautious with what we glean from calprotectin. And fecal elastase has also been validated. There's good data for calprotectin, again in IBD, and fecal elastase in those who have an inability to tolerate certain foods, most namely fat, and they will respond very well to supplementation with pancreatic enzymes like creon. Now, that being said, in the clinic, I've found the success rate, if you will, in terms of someone who has a low, therefore positive fecal elastase responding to enzymes being fairly disappointing. And I think this is because, and this is my theory, this is my speculation, but because we are intervening with dietary, lifestyle, and other natural supports like probiotics and elemental diets and potentially antimicrobials, I think what's happening is we're resurrecting or repairing the ability of the pancreas to secrete pancreatic enzymes, and or we're getting more endogenous brush border enzyme secretion as we're healing the lining of the gut, the microvilli that also secrete enzymes. Therefore, it's reducing the utility of the enzymes. Now, that being said, I should be very clear in acknowledging there is good data validating fecal elastase, so it is something to consider. And not helpful, testing for dysbiosis, although the GA-MAP test, which has been pioneered in Norway and is now included in the diagnostic or doctor's data testing, that has been validated. But validation is different than saying it helps us treat you any better. So what we do with the validated dysbiosis data is a big question mark. And also microbiome mapping, like I was mentioning a moment ago, I was reading a user report of someone who took one stool sample, split tested it at 2 different labs, and saw vastly different, in this case, it was the Firmicutes bacteroides ratio results. When they were investigated by the FBI, unfortunately for insurance billing fraud, they also found that they were using dog feces in part to establish the normative ranges for humans. And this is why, as it pertains to gut biome testing, it's important to clarify that there's research being done here, and we're still trying to learn more and match certain skewings of the microbiota to certain disease populations. This does not mean it's ready for clinical use for your doctor to be, or your healthcare provider to be able to say, well, because of this, we should do that. And I just want to tie into this that for years, patients and providers were treating ubiome lab results and proclaiming that it was helpful. And that just can't be the case. Now, what could be the case is you are taking an action. You're increasing fiber in your diet. You're eating a healthier diet, let's say. Or you're using probiotics, or using prebiotics, or using antimicrobials. All of these things we know help. But you don't need to be spending hundreds of dollars on a test to inform those therapies. Those therapies work no matter what. So you could do a dog poop test and then go on a healthier diet or take a probiotic or take a prebiotic and see a response, and you could conclude it was helpful, but that actually would be very inaccurate and unfortunately often occurs at the detriment of the patient because now they're limited to treating the test and spending money that they don't need to. So hopefully that makes sense, but really important to clarify, you can use an inaccurate test and then go and do a therapy that we know is helpful because there are randomized controlled trials showing a therapy is helpful, and there can be no connection in between the two. And it's a really key concept to understand because it prevents one from wasting tons of money on these speculative lab tests, and there's obviously a huge market for it because you are seeing every few months a new lab pop up proclaiming to do XYZ. So we want to use lab testing where we can and to help an individual and be progressive. On the one hand, we also want to be careful not to waste time and money on the other. And then as it pertains to dysbiosis, just kind of a quote for you here, or a thought. When it comes to dysbiosis, it's really better to treat the person and their symptoms than to treat the lab values. And part of the reason for this is, again, we don't have any data that has yet told us what is the most successful way to treat dysbiosis. We know that, again, in a small handful of studies with the GA-map technology, that test, that stool test, can discriminate healthy versus IBS versus IBD. Yes, but there are no datum that have said if you see this pattern of dysbiosis, they require a probiotic or this diet or this herb or this antibiotic. So we want to, again, be careful not to treat the numbers in this case and treat the person, because if you look at someone's symptoms and say, there are clinical trials that have found this grouping of symptoms responds well to this therapy, that seems to be the much more expeditious way to go and also less expensive.